My name is Shankar Sastry, and it's my great pleasure to welcome all of you to our program this evening. I really look forward to our Dean Society gatherings with great anticipation. We enjoy having the opportunity to thank all of you for your support of Berkeley Engineering. At the same time, you have the opportunity to take an insider's look at the research and teaching happening every day here in the college. Before we begin, I'd like to acknowledge Bill Floyd, Chair of our Berkeley Engineering Fund Board of Directors, for his generous assistance in securing this beautiful facility at the Menlo Circus Club for tonight's program. Bill is tireless in his efforts on behalf of the college, and we are very grateful. Now, if I can locate Bill.
Right here.
Oh, sorry. Dylan, thank you. Sorry. I'm especially enthusiastic about today's program, Health at Home. It's no secret that the challenge of delivering high quality and cost-effective health care is a goal we are striving towards as a society. However, when we step back and take the big picture view, we're able to see a remarkable convergence happening in healthcare. Convergence is bringing together three domains: technology innovation, translational medicine, and systems engineering, to build the healthcare model that we so urgently need. In a new model, we should be able to monitor and manage our own health in our homes or on the go, thanks to precision diagnostics, treatments, and alerts that have been developed with an eye towards marketplace adoption and cost containment. This model embraces both everyday preventive care as well as follow-up care after a hospital stay, both increasingly important as our population ages. We are building on this model right now at Berkeley. We have invited Children's Hospital and Research Center of Oakland and UCSF's Clinical and Translational Science Institute in as our strongest partners, both clinically and research-wise, and we are really thrilled to be able to collaborate with them. Collectively, as a result, we have some of the best minds in the health sciences working with us on this issue. Our Health at Home initiative is developing new technologies that allow people to capture their own health information, watch for early warning health problems, and tap into healthcare services, even quite sophisticated services outside of the hospital. At the same time, we are pulling in our systems engineers to help us target the technologies at the costliest parts of our current healthcare system and design the new home healthcare network for optimal quality assurance and cost effectiveness. Health at home is a key part of a larger effort we are undertaking in the college to engineer better health through research advances as well as undergraduate and graduate education. Our bioengineering department, for example, has grown tremendously since its establishment in 1998, and it attracts scores of students interested in biomedical technology innovation. By the way, our founding chairman is Tom Budinger is here, and I wonder if I can locate Tom. So, Tom, there you are. That said, every one of our 7 academic departments is active in generating new and improved healthcare solutions. On the educational front, the Master of Translational Medicine, a joint program with UCSF, is now in its 4th year. Kyle here is the executive director of the program. This program teaches students how to bring new treatments and devices into clinical use. Andy Grove challenged us to launch this program because he saw no reason why healthcare couldn't innovate as rapidly as the semiconductor industry. Engineering better health continues to be a key priority for the college, and we welcome your ideas on how best we can match our research and teaching strengths with the need to find cures and improve the quality of life. And my job, of course, is now to introduce the panel and get out of the way so that you can hear from them. So let me introduce the panel. Dan Fletcher, starting alphabetically, starting with Dan Fletcher here, is professor and associate chair in our bioengineering department. With his students, he develops new biomedical devices to collect health information and studies the mechanics and dynamics of cell movement involved in disease. He's also known as the founder of this CellScope, which is now, I heard, in Verizon ads for, for diagnosis with microscopes and so on. Clay Johnston is Associate Vice Chancellor for Research at UCSF and our partner in launching the Masters in Translational Medicine. He also directs UCSF's Clinical and Translational Service Science Institute, CTSI. Under his direction, CTSI has become the hub of UC-wide efforts to accelerate research advances towards improved health outcomes. Phil Kaminsky chairs our Department of Industrial Engineering and Operations Research. He's the site director for the Center of Excellence in Logistics and Distribution, which has a special initiative focused on making biotech operations more reliable, and I think his partner in crime is Marilee Brooks. Marilee is here too. There you are, Marilee. Bert Lubin is President and Chief Executive Officer of Children's Hospital and Research Center, Oakland. He oversees both a medical center devoted to children. I think most of us have had a child go to this hospital, so I'm sure no stranger to all of you, as well as the Medical Research and Education Enterprise, Corey. Grace O'Connell is new to Berkeley. She joined us this year as an assistant professor in our Department of Mechanical Engineering. Her research focuses on soft tissue mechanics and tissue engineering, especially as they relate to back care. Lydia Zone is Associate Professor of Mechanical Engineering at Berkeley. Her research is in micro-nano engineering, and she's currently working on a point-of-care diagnostic tool for cancer diagnostics. I've invited each of our panelists to speak for a few minutes about their own work as it relates to the Health at Home initiative. And I think I'll just introduce Bert, and I think they know the order. So please welcome Bert.
Well, thank you very much for inviting me. This is an honor and a pleasure. This has been a remarkable day because at 8 o'clock this morning, I gave a talk and Elmo was with me from Sesame Street. And we talked about a project that Sesame Street is undertaking, and that's for the parents of the children whose parents are incarcerated, of which there are 2.7 million children in the United States whose parents are incarcerated. And you can imagine what their lives are like, and no one really pays much attention to them, and the healthcare needs that they have are really dramatic. So here we go from that talk to this talk of advances in science and home health. I'm honored to be here because I do think at Children's Hospital in Oakland, which I've been at for 40 years, and the hospital is 100 years old this year, we have a safety net service that provides service to 250,000 children's a year, visits a year, an emergency service of 50,000, and a very large program that really needs to focus on prevention of illness. When I went to medical school, the goal was keep kids out of the hospital. Now that I'm a CEO, if I don't keep kids in the hospital, I don't have money to keep kids out of the hospital. So the system is the opposite way it ought to be directed. And I think with engineering input and the knowledge that's here in this room and the relationship that we plan to develop with UC Berkeley and with UCSF, we'll have a chance not only to prevent illness in children, but to develop a home health project and to maintain the health and well-being of children. We're very firmly convinced that the social determinants of illness that are besides the illness itself have a great impact on outcomes of medical care, and that if we don't pay attention to the total complex picture, we'll use a bandage to treat asthma, but really asthma is going to recur and the costs are going to be here. We are a country, as you well know, that spends more on health care than any other country in the world, and yet the outcomes for our health are not the best in the world. So with engineering, we're going to change that. And I'm really excited to be part of this. I want to let you know that by the end of this year, we hope to have a formal announcement that Children's Hospital in Oakland will become affiliated with the University of California. that UCSF and Children's in Oakland will be a new enterprise improving the quality of care for children in Northern California and working together with the Berkeley UCSF Bioengineering Group to advance the care of children. So again, thank you for inviting me here, and it's an exciting time for all of us.
So I'm Clay Johnston. I'm a neurologist. I am an epidemiologist. I do stroke clinical trials, and all of that. As I was doing all this, I was working in those fields. It just it struck me just how poor a job we were doing. So for one thing, the research engine, I'm deeply embedded in the research engine, is just too slow. And it's taking too long to come up with new therapies. And if you look at what goes on in health and how the advances occur in health, it's a snail's pace compared to what goes on in technology. So what the heck? I mean, in technology, things have dramatically altered our lives. In the health arena, technology touches a few devices. We finally have an electronic health record, which doesn't work as well as Microsoft Word. It is primitive on that side. So the other major problem we have actually is, and you mentioned this several times, Shankar, is that every time we innovate, we increase the costs. That's true of devices, that's true of drugs. In our healthcare system just keeps on like a mud ball, not a snowball, that's too clean, picking up more stuff as it goes down until it's just unmanageable. Technology has dramatically reduced costs almost everywhere else. Why hasn't it been applied to health, and why couldn't it be applied to health to reduce cost? So one of the most gratifying relationships we've had is with Berkeley on the UCSF side, and Berkeley Engineering in particular. And that was the partial realization that, okay, clinicians have a certain way of doing things, and it's sort of stuck in their mind that's the way things have to do. And they have a certain perspective, and it's stuck in their mind that they must maintain that perspective. And on the engineering side, they're problem solvers. They like to look at problems with a fresh perspective and look for often more efficient answers to meet the needs in those instances. So different perspectives are absolutely critical to addressing problems in a fresh way. So bringing those camps together, you begin to realize the potential of bringing these groups together. Now, both sides are really important to each other. So I'd say on the clinician side, it's not just that they don't understand technology, it's that they really do think differently. They think about this individual encounter that they have with patients. We really value that in society. We want to maintain that. But that prevents them from thinking about the broader perspective of how they could deal with a panel of patients, hypertension in a group of people, not just in the person in front of them. But on the engineering side, they think of this, cool new sensor that can be created, or neat bit of software that could be built, but often don't have the grounding to understand what clinicians really want, what could improve care, and actually what could be welcomed into this very broken healthcare system, which does not respond like the tech world does, where you come up with a great idea and it sells and everybody's happy. It doesn't work that way on the health side. So those two perspectives also are absolutely required in order to make progress. And digital health's doing great, right? We've seen all the VC money being thrown at digital health. But from the clinician's perspective, when we look at some of those companies, we're like, there's just no way. There's no way they're gonna make it. And some of it is clinicians do not want more data. They do not want your sensor data. And in fact, the studies that have looked at adding sensors in out of hospital care have not shown that it improves outcomes, and it does drive up costs, not drive it down. So we need to have the discipline that comes from really understanding what's needed clinically. And that's not the data, but it's the information that can come from the data. So what is it that could be acted on, and could be acted on maybe without a physician being involved, that could actually streamline care? It's those sorts of opportunities where taking those two perspectives, bringing them together is going to be absolutely critical. So I'm excited about where we've gotten so far. Master's Translational Medicine's program's been great, and we're working on other programs together, and I'm very excited about the potential to take, the absolutely most fabulous engineering department, engineering school in the country, and bringing it together with a top-notch medical school.
Thank you very much. It should be no surprise to anybody that he's a Cal alum, huh?
All right, good evening. My name is Fletcher. I'm in the Bioengineering department, and my lab, as part of our work, develops technologies based on mobile phones. So let me start with the story. So as a kid, whenever I would go swimming, I would get an earache. Oftentimes, whenever I would take a shower, I would get an earache. I had earaches all the time, and I took countless trips to the emergency room because it was so painful. And those trips were no doubt costly to somebody, my parents perhaps, our insurance company, no doubt. And those were the kind of trips that were disruptive in all sorts of ways. And what the physician did, or the emergency room attendant did, would be to look in my ear, to try and examine what was wrong, what was causing the problem. Did I have an earache that could be treated? Is this something that I should wait and watch? Rendering that diagnosis depended on an experienced eye looking at the problem and rendering a judgment. And not a lot has changed in many years, that we still rely on the experience of physicians to look at the data, the person, the problem, and decide what should be done based on that image. So a number of years ago, as a result of an undergraduate class at Cal, we started to think about whether we could use the cameras that were appearing on mobile phones to do the kind of imaging that a physician might do in order to render a diagnosis. And based on some very talented undergrads, and actually with some help from our dean, some financial support from our dean to get started with a little seed project, we developed a way of magnifying images onto a mobile phone so you could capture information from the kinds of samples you would be providing to a physician, a blood sample, other types of samples. And that project has grown over the last number of years, and we've been able to make devices that emulate much of the capability of the microscope that's used in a pathology lab, that's used in a research environment to evaluate samples. And some of those devices are here being shown by some very talented students, Clay and Arunan, to show you what our latest devices do. And this ability to capture images and transmit them to the physician has the potential to disrupt the normal flow of events. Rather than me having to be shipped off to the emergency room or make an appointment with a pediatrician to get my ear looked at, that kind of capability could be done maybe at a school nurse's station. Maybe that could be done in a supermarket. Maybe that could be done even at home one day. So to be able to capture these devices, it's really thanks to all of us who are eager to have the latest and greatest mobile phones. So we will purchase, many of you probably had an iPhone 5, and then iPhone 5S came out. You're like, oh, got to have that. And so you got that. And that constant desire to have better capabilities is making these devices into something that can capture tremendous amounts of information, some of which can be useful for evaluating whether you should go to the hospital or not. And so that's work we've been doing both in the context of global health, as well as starting to think about how could those devices be used in the context of the home. How could you take information that on a day-to-day basis, monitoring might help you make a decision about whether to go see your physician or not? How could you capture that, and what's the right way to do it? And that's really a major goal of the Health at Home effort, is to try and move the technologies forward in partnership with the physicians who we rely on to do that final interpretation. What is going to be useful? And then together with systems people like Phil Kaminsky, where can we reduce costs in the healthcare system? That's been an effort that we're very eager to engage in. And so just to come back to that that first story of this earache, we decided to see if we could mock up something for a mobile phone that could look at the eardrum and do the same sort of image capture that an otoscope, which today a digital one costs a few $1,000s. So we were able to make one, prototyped it in lab, and then a couple of Berkeley graduates spun out a little startup company. And I'm very happy to show you a box. Nothing is really a product until there's a box. And there is now a box associated with the otoscope, and that's going to be coming out in a few months. And so this device, which starts with a need that is either something we all have experienced or one that physicians help us to understand could help to cut treatment times or reduce the cost of care. This sort of technology is something that Berkeley is expert at developing. And so that's what we want to continue to do. But just like I had a personal experience with ear infections growing up, we're very eager to get input from all of you on what should we be thinking about? What are the types of measurements that, if we could do them at home, how would they impact your lives? And so you may have noticed in your program that there are a few little Post-it notes. Those aren't intended for you to make grocery lists for your way home. Those are intended for you if you have ideas, if you have in the last 6 months, if you've had to have a test. Could that test have been done at home? Is there a monitoring that would have saved you a trip to your physician? We'd love to know what kind of thing you have had an experience in needing measured. And then we have a couple boards there in the back that say health at home. And if you're willing to share your experiences, your needs with us, we'd love to use that as a motivation for the next kind of devices to build. So with that, I'll turn it over to Lydia.
Wow, thanks, Dan. Well, like Dan, my focus in my research is also a personal thing. Cancer diagnosis, I have 2 parents who are survivors of cancer, one prostate, one lung cancer. And I have watched them, they live in New Jersey, and I have watched them make the trip into New York City on every emergency visit from monitoring of their therapy to just some scare that they had. And they would always tell me that trip through Lincoln Tunnel was the longest trip that they've ever taken. And then, of course, it's 5 hours in the ER room at Sloan Kettering, and then, in the end, it's okay. Everything turned out to be normal. So I'm motivated in trying to see if there's a way that we can actually have the patient be able to monitor him or herself at home and be a partner with the doctors, to phone in at a certain point, like, okay, these are what my numbers are, and so forth. So what you'll see back there with my group, what we've developed is a pretty much of a universal device that is based upon electronics. That was my background before I came to Berkeley. And really, it's a way for a patient to be able to do CBCs at home instead of going to Quest Diagnostics, instead of waiting for that CBC result in the ER room. Again, we always joke it's always 5 hours. No offense to the doctors here. Like it's always minimum 5 hours. We want to speed that up. I mean, it's just patience, really. And the other thing is just to be able to diagnose and monitor therapy. There's an aspect of my research where I'm trying to be able to look for that needle in the haystack, to be able to identify the few 5 to 10 circulating tumor cells that may be circulating in someone's body after being diagnosed with cancer. And there are clinical trials or studies that show that the more circulating tumor cells you have in the body means that you're more likely to have a poor prognosis. I'd like to be able to do that for my mom who has lung cancer. Like to be able to tell her, oh, maybe it's time you should go, check up with your oncologist, and be able to do that at home. There's some sense of ease of being able to do all of these tests at home. There's just the patient's more relaxed. And then there's other cases where I'm working with a very good friend of mine at Chicago, where we're looking at being able to diagnose something called acute promyelocytic leukemia. And in that case, you have basically 48 hours to diagnose the patient. The patient is bleeding out most often, and you can give that patient one drug, a pill called Atra, and that forces the patient into remission most of the time. And unfortunately, by the time the patient is diagnosed, because the patient's waiting, as we all do when we're at home, we're not feeling so well, and you're just sort of pushing, should I go or not go to the ER? By the time the patient, most of the time the patient comes in, it's late at night, pathologist at home, et cetera. It takes time to actually do these tests. By that time, if you miss that 48-hour period, then unfortunately the patient most likely ends up dying. And my friend has actually had patients that have died, and she knows that the patient has this disease, but unfortunately it has to be officially confirmed by the path lab in order for the insurance companies to say, okay, you can give that patient the drug. So we like to, this is a very special case for us, but we like to be able to have that patient, if anything, at the doctor's office or even at home, go ahead and test it out. It doesn't harm, it doesn't, we like to just speed up the whole process. We want to be able to save lives. And incidentally, APL is not a very, it's a rare form of leukemia, but especially in South America, it actually is one of the, it has a 50% incident rate. So it's almost hereditary, I would say genetic. And their death rates are very high because the pathology labs with the special instrumentation are not available. And we like to be able to just have these things, like we like to have a cell scope. And maybe we should work together, Dan, together. But essentially, we'd like to be able to have something portable that's very cheap and that people could use in various areas. So again, cancer is personal for me, and we just like to be able to, I'm really motivated to really try to make streamlined things so the patient can stay at home and focus on getting well instead of being stressed out. So with that, I'll hand it over to Grace.
Hi, my name is Grace O'Connell. I'm the new faculty member in the Mechanical Engineering Department. And my research is based on the musculoskeletal system, and specifically with the spine, because it's the second leading cause for disability in Americans with low back pain. And I'm focused on disc herniation, because with that case, that usually happens when your disc is healthy, and the surgeon would take out the tissue that's causing your low back pain. But this can lead to changes in the mechanical function of your spine, causing further degeneration, which can lead to other problems that will cause you to go back to the doctor. So we're looking at just understanding how this disease progresses and ways that we can actually intervene early with a biological repair strategy to help regenerate the tissue that we're taking out or to replace it with something more biological based. So that's basically what my group is developing at Berkeley, and I have a couple of my undergrads here today presenting the work. There's a poster over on the left side also showing this as well.
So I'm Phil Kaminsky. I'm chair of the Industrial Engineering and Operations Research Department. And in my field, all over the country, everybody's turning to healthcare systems engineering. This is absolutely the growth field. Every department is hiring in that area. And almost all of this work has to do with improving the operations within hospitals, which is very important. But if you, one of my favorite quotes, the CEO of Kaiser on the front page of the New York Times a few months ago said, at this point, to get costs down, to get healthcare costs down, we have to move care out of the hospital. And to me, this is what's so exciting about this Health at Home initiative. It's this notion of allowing us as systems engineers to really make an impact on moving care out of the hospitals in sort of expediting discharge and decreasing readmission. And it really plays to all the strengths of our department. This whole notion of systems analysis, this notion of understanding how all of these great inventions can impact the entire system. Where does it make sense to allocate resources? Which kinds of inventions, which kinds of technology can have the biggest impact in lowering overall health costs? It's really a big part of what we do in our department. Another thing we focus on is network design. And really, if you're moving healthcare out of the hospital, you need a way to get all the stuff, all the people, all the technology, all the drugs into homes in an effective and efficient and trackable and traceable way. And that's another big part of what we do. And finally, sort of one of our biggest growth areas, an area that we've been hiring a lot in lately, is this area of behavior modification and incentives, right? So we know that to control obesity, we need a certain amount of exercise, and we need to control diet. But the larger question is, everybody knows that. How do you design incentives and everything from web apps to other kinds of incentives to encourage people to achieve these goals and to sort of dynamically update their goals. So all of these things are things going on in our department that really fit nicely into this Health at Home initiative. And it's particularly exciting. Most places in the country, when we get involved, when system engineers get involved, the technology has already been developed, and we kind of have to figure out the best way to make use of the stuff that's already there. But here at Berkeley, we have this vision of integrating this kind of system analysis, this kind of behavioral modification with the device invention, right? So I can talk to these guys and I can say, look, these are the areas that really we can make an impact. Of the kind of technology that you have in your labs, if you focus your resources here, this is how we can get down healthcare costs in this country. And this sort of collaborative environment that we're working so hard to establish here at Berkeley in this area, I think really has the potential to make an impact in ways that in other places where people are sort of off playing on their own, just can't leverage the same kind of invention across the college. So it's really exciting to be a part of this initiative, and I'm very excited. We're going to have a workshop in the spring where we bring people from all over campus together to start talking about these areas, and I really think we have a tremendous potential in the near term to really impact healthcare costs in this country.
Invite questions from the audience. Jane's wandering around with a microphone. But Bert, while we are waiting for a question, I mean, we had a wonderful discussion right before the session about some of the initial kinds of things we could be doing between Children's and UCSF and these wonderful bioengineers here. So
Yes, okay. At any rate, we talked about 3 projects that we could look at together. And when I say together, it's UC Berkeley, UCSF, and Children's in Oakland. So the first one relates to a sports medicine program, and we have a really phenomenal sports medicine program that represents a partnership between the orthopedic program at UCSF and Children's Hospital in Oakland. We have a gait lab. We have a number of children that have sports injuries. We'd like to prevent the injuries. We'd like to particularly be able to assess on the playing field if an injury occurs that's of significance to the child, and not have them go back again, or be back on the field again, or be sure that they see somebody in the very near future for care. We know that there's long-term impact of head trauma. You don't appreciate it immediately, but the consequences of that are great, and the costs are great. So this is one area that we've decided is an area that we should investigate together, and it's an area where there aren't hundreds of other groups investigating, and we think we can make a difference. Another area is to data mine the systems that we use with our electronic medical records. We are 1 week into initiating our electronic medical record at Children's. That's called, the one we use is Epic, and UCSF installed Epic, and so we'll tie the two together once ours is together. And for any of you who have been involved in those activities, it's not trivial. But we're making progress, and the doctors seem to be pleased for the most part, and I am a pediatrician, so they know that I understand some of the challenges that come up with that. But if we could mine the system to pick up a lot of social determinants and other factors that attention needs to be paid to if we're going to improve health care and decrease costs, and if we could also implement those in a home environment, just as you've heard the speakers talk about, I think we can make a major change in the way health care is delivered and be a program that then is disseminated throughout the United States, if not world, to improve the health care of children. And then the third is the work that Dan was talking about. We are a big center in sickle cell and thalassemia. These are genetic blood diseases that are worldwide, the commonest genetic diseases in the world. And to do prevention and treatment, you need to have access to technology that can be brought into the field. And if you take a look at the cell scope that Dan and his group developed and the other technologies, it's phenomenal that you don't need to have, that you can transmit information from field work either back to us or to a local laboratory and really prevent illness. And I think that prevention really has to be the keynote, and all of the technologies that we're talking about here have to really address prevention of illness, because that's the only way we're going to decrease cost. And if you prevent illness in children, you prevent illness in the society.
Oh, right, okay, if you're ready, yes.
I want to ask, from the point of view of patient, how do we, can the new technology help us to manage our own medical record? Because all the physicians in different specialties, they are all in silos, and you depend on your primary care physician to coordinate. But usually, I found that from our own experience, I have to keep my own medical records.
Yeah, yeah. So that's a big mess right now, and it's going to take us a while to the system a while to work through that. I'm not taking responsibility for this. I'll say the HIPAA, the way what does it even stand for? Health Information
Privacy,
Portability
Portability.
and Accountability Act. In it, it says that you have the right to a copy of your electronic health record as soon as you ask. So that means that wherever you currently get care, if they did it on paper, they had to Xerox it for you. Now they have to give you a full copy of your record. Now, fortunately for the systems that are in place, people don't ask, because they couldn't tolerate the demand right now. There are no systems in place to actually make that happen, and that's what you've discovered, right? So that would be the simplest thing. Of course, when they give it to you, is it compatible with the hospital system that you go to next? The answer is no. That sort of interoperability is not available. But actually, it ends up the VA hospital was the first one to come up with a simple system called the Blue Button system, where you can take their complex medical record and out comes a digestible medical record. I think they use XML, right? So it's easily transferable to other systems, and now the others are following suit. So the Epic will have such a thing within the next couple of years. So you're seeing some rapid improvements here, but a lot more needs to be done. The other thing is, when you get an electronic health record, does it make sense to you?
Because I have background in biology, so I can...
So it does to you, but I would say that 99% of people who get it, it doesn't make any sense. And that's the other problem. We haven't thought about who the consumers are for the electronic health record. It's not just the people, providing care. There's another piece to that. And that communication needs to be much better. That would improve health dramatically. That's an engineering problem, actually. So how do we get this complex data that is in front of physicians, which is already way too complex for them to digest, and then make that sensible in a way that the patients can understand? That's a great problem that somebody needs to work on. Maybe Phil down there can give us a solution to it.
To the list, yeah.
Tom.
So I really have a lot of respect for Bert, but I disagree that the only thing is prevention, and I'm sure he'll agree. So I'd like to tell you a little story. I thought I'd pick on Dave Bougie, who's right in front of me, because he's a mechanical engineer. Now suppose Dave is on the football field, and he's running for the goal. This is based on a true event. And he has a fantastic capability of leaping. And just as he's about ready to be tackled, he leaps in the air. The guy tackling him comes in from behind, throws him up even higher, total of maybe 15 feet in the air. He flips over, and he lands on his tush. Now, this is a mechanical engineering problem. What part of his body is most likely to have a contusion injury? So he's coming down, His brain is coming down, floating inside his skull. His tush hits the ground. It stops, and his brain is still moving, so it's the base of his brain. So most of the fatal collisions, when looked at, find that the damage is mostly to the base of the brain. What is in the base of the brain? So how many people, I'm not going to ask you to hold up your hands, but how many people here consider fibromyalgia an impossible disease, maybe psychological, impossible to diagnose, just a terrible state of life? So what percent of military people, car drivers, sports people who have been in a concussive-like situation have a significant decrease in principal hormones of their body? 41%. What are these hormones? One of the hormones, now I'll pick on Patricia, bougie. One of these hormones is called oxytocin, comes from the posterior pituitary. What about growth hormone? Growth hormone doesn't have to do with growing today, has to do with your brain metabolism, repair tissues. So before the dean gets concerned that this is going to be a longer and longer lecture,
You got to watch out for professors once they start, huh?
I'd like you to think about the base of the brain, pituitary, 9 hormones from the pituitary, and the fact that it's demonstrably decreased growth hormone, thyroid stimulating hormone, oxytocin, vasopressin. So those are just 4 that have to do with the functioning. Now, if you ask for the symptoms of post-traumatic stress syndrome, the symptoms of fibromyalgia, look at those symptoms and then look at what those hormones do. You say, oh my God, this is a no-brainer. Here's the problem, Lydia. We don't know how to measure these at home for less than $400 a kit. They're difficult to measure, but it's a problem for you. So you ask for ideas. Here's an idea. Figure out how to measure these hormones at home, particularly in children.
Thank you.
I don't know if there was a question, but if somebody feels like responding, it's okay with me. Please, Dan. Okay, so oxytocin measurement. So let's get that on one of the stick-ons there.
I'm curious, any 2 of the panel members would agree on why our healthcare costs are so high compared to countries that have better outcomes at lower cost?
Clay and Bert, I think.
Yeah, there's not one, I mean, that's too long, and we should talk about it later. There's so many reasons. I mean, insurance costs a lot of money. Because we're fee-for-service and we're very entrepreneurial, we use a lot more healthcare, and it doesn't necessarily improve outcomes. Those are actually the 2 biggest pieces. Physician salaries are pretty similar across, so it's not that we pay our people better. It's that we consume more, but get less out of it.
So I'll speak to the pediatric part of that. So if you take a look at children that have medically complex illnesses, which represents 6% of all children that are sick, a small percentage, in that 6% are 80% of the healthcare costs. So when there's multiple aspects to an illness, we haven't managed them in a way that's more efficient. And I think whether it's electronic medical records, whether it's a whole different system, whether it's home health, but there have to be approaches to address the management of a medically complex illness in children if we want to decrease the cost.
So this is a really good conference. All the panels, you present a lot of good ideas. Really second to Dr. Johnston's opinion about how to connect the engineers and doctors together to solve the biggest challenging problem in our society. I can tell you a little more. Actually, we need MBAs too, and the lawyers too. The gentleman just asked how to reduce the cost and improve the quality. I can tell you the key answer of that is disease prevention. And in this country, yes, we have a lot of cost. Frankly, a lot of this is unnecessary access.
So, there wasn't really a question, but I'd like to invite Clay to talk a little bit about, involving business and law. And, I want to plug our own Masters in Translational Medicine. So I'm going to ask, since it's a joint project, I'll ask Clay to plug it.
Definitely agree. It's not just about engineering in medicine. I mean, law is critical, business is critical. In this Master's Translational Medicine program, we have actually tried to give training in all, not in law, but in all the other areas, make that available to trainees. Many of them are coming from engineering background, more and more they're coming from MD backgrounds actually. And that program seems to be working really well. I do agree with, I want to change slightly something that you said. The things that we heard on this panel and the things that are coming out of Berkeley are absolutely fabulous. The potential to change health is right there. But you're absolutely right. The solutions aren't just going to be, it's partly talking to clinicians to figure out practically how it's going to work, but it's also figuring out the business case for it. So CellScope, I mean, what a great thing. But who's going to buy it and how is it going to drive down cost? That's the critical question. How, is it moms? Is it I can imagine a payer might say, okay, we've got these kids who have frequent ear, just like you, and they're coming into the emergency department, they're costing us a lot of money. We're going to buy this and distribute it to those kids. We can identify them through our electronic health record. We know they came in 3 times last year to the emergency room. We're going to train their moms to use it. That's an example of how, so then how do you create that scheme to distribute it and to make sure that the insurance companies will pay for it in that setting because it's driving down costs? Those are the critical questions that need to be addressed to make these things scalable and work. MTM's in a good place to do that, and some of the other programs we're working on will help too.
Yeah. So it is, first of all, thank you for all for... Thank you. Thank you all for being here. Your outreach to the community is really quite something that's extraordinary and is almost unique to Berkeley. Berkeley does a better job of this, and the School of Engineering does an exceptional job of this. So thank you. The vector for health at home has come about in the last 5 years, and it's really come about with the advent of the smartphone and with the advent of Wi-Fi ubiquitously in people's homes. And what I've heard from the panelists tonight is extraordinary passion around points of innovation, around solving individual problems that you see solutions to, and that you're passionate about solving. And those point innovations, while very valuable, I'm wondering whether Berkeley isn't in a position to take a larger view and to look at the problem from a clean slate level and look at this and say, we have a new platform. We have a clean slate, a new architecture on which we can build solutions for home healthcare delivery, for diagnosis, for patient counseling, and for connecting the rest of the healthcare system with patients. So my question to you is, what thought at the systems level with this new architecture, the greenfield opportunity that's here, presented by Wi-Fi and presented by the smartphone as a platform, what systems level thought is being given to that problem?
All right, Bert, go.
I can talk a little bit about this. When we sat down to articulate our health at home vision, our notion was not to start with the technology, but to start with the opportunities. So not to start with either individual points of technology or kind of this technology platform, but to first start with identifying the places that we can make the biggest impact. And then so this is what we do in systems engineering, and then to talk with the platform people, whether they're in electrical engineering or they're in bioengineering or mechanical engineering, as well as the doctors, to say, given first of all these needs that we've determined, or our analysis suggests could make the broadest impact on the healthcare system, and we understand unintended consequences and so forth. Once we build those models, then we can start seeing how those dovetail with the technologies that are being developed and could potentially be developed on campus. So this is kind of the vision that we've been kind of kicking around for the past year as we try to develop our overall strategy for health at home. So I think this is something, I mean, we haven't figured out how to do it yet, of course, but it's certainly something that we're conscious of. We feel like there are lots of great inventions, but it's always been sort of ad hoc whether they significantly impact the healthcare system or not. And so we'd like to take a more integrated approach to try and do that.
So I just want to add briefly, and it's a little bit on takeoff of what Clay said, and that is, you're talking about population health. How do we look at a population and improve their health? And if there are many people with diabetes, or many people with hypertension, or many people with heart failure, that you look at how you address this in a population system. And I think the engineering concepts that you're mentioning are going to be the ways we have to look at this. And I don't think from a clinician standpoint, we've looked to engineering as much as we need to. And I think this is a new way now to open up a new field that I think is really extremely important and very exciting. And that this lead program between UCSF and Berkeley is going to really foster that.
Yeah, you're absolutely right. I think the other piece of it is if we expect to deal with this piecemeal and then solve the business problems at the other end, then it's just really a wasteful slow. There'll be a lot of false starts. I think the real way to do it is take a payer. I mean, if you look at how much we consume in healthcare costs, it's huge. I mean, these projects could all be funded on 0.25% of Kaiser's annual budget. I mean, it's just tiny. So take a payer like that where they're motivated to reduce their costs and partner. And then you've got a population that you can work with and a potential EMR platform upon which you can build your innovations. All this data can't just sit out there with the patient. It has to go back into the health system somehow. And the health system data has to come out. That requires a partnership already. So I think there are opportunities there. No one's done that. And I don't know, are we set up to do that in California? We're not, Kaiser is unlikely to do this in partnership. We're starting to see more ACO-like populations. In San Francisco, we have the San Francisco Health Plan, for example, that runs that way. So there are ways in which we could explore it, but we're not quite there to do it at scale.
Should we take the last question from there?
Right
there.
next to
Hi, in terms of what the technology can achieve here, I think I heard that the clinicians don't need more data. So we have all cell phones, so of course we have a lot of endpoints and a lot of data can be amassed. But what I heard is that we need a way to transform that into actionable things, right? So the question for the technologists is, can you speak to the challenges for achieving that? So transforming data into actionable items.
I can maybe take one stab at that. So actionable data, I think it's a great way to phrase what is needed. And sometimes that actionable data is the data that the physicians need to look at. And sometimes there are ways of figuring out whether you need to take action on the data. And I think that's where some of the smartphone technologies can really help. So for example, with the Otoscope project, right now, as a result of a number of physicians working with these devices already, we've amassed a very large database of images of eardrums. Now that's not something people typically like to collect, images of eardrums, but because all of these are linked wirelessly into a single large database, together with the diagnostic decision of the physician based on that image, there's now an opportunity to develop algorithms that can help to decide or at least suggest what course of action should be taken. So that's a way where the massive data that maybe is not going to be as useful piece by piece to physicians, we don't want to flood everybody with more images, but maybe expert systems, algorithms, machine learning can be used to provide some guidance. And that's one way that the data can start to work to interpret the next bit of data.
Phil, do you want to pick up on this? Data analysis, data analytics in the cloud?
I think this notion of transforming data into information is sort of pretty fundamental across the campus, and certainly we see that as an opportunity to really impact healthcare, and this is why we just hired, pointing to a new colleague here, Neil Aswani, we decided to bring in a machine learning expert specifically to address these kinds of issues, to understand how you can take this data, develop adaptive schemes to control interventions, and to really avoid just presenting large quantities of data, but really present information and decision support.
All right. This is a fascinating conversation. As you can see, this could go on for a little while. We were going to have this exercise of asking you for your suggestions in real time. But I think, as you heard from Phil and Dan, and we're going to try to have a workshop where we take the ideas. So may I please request you to take a look at those stick-ons there, and as you have a drink and have some real dinner. I was told there's real dinner to follow here, not munchies. Please let us know about your suggestions, and we'll take it to heart and compile them and share them with our faculty. By the way, this concludes the panel discussion part of our program, and it'll be on the Berkeley Engineers YouTube channel. That's why we were making sure that everything was recorded. We've invited several of our students to join in the reception, and also some faculty. He plugged Anil Aswani, who's about as newly minted as Grace on our IUR faculty. Terry Johnston, who runs a lot of these projects. Kyle Kaminsky, I got Tom, and Dan Motors, mechanical engineering. I think I got all the and Kathy Costland here from. You're also an engineering professor, right? Civil and environmental engineering, and public health, and vice provost. How's that? They've brought the students, by the way, as you know, in these events, the students are always the highlight. So I really would like you to enjoy their posters. Please take a moment to talk to them. And once again, a really hearty thank you to our Dean Society supporters. We truly could not fulfill teaching, research, and public service mission without your generosity. And if you haven't renewed your support for 2013, please consider making a gift by December 31st. And thank you for joining us this evening. Please enjoy the opportunity to talk with our panelists and students. And go Bears!